Welcome to the deep dive. Today, we're really digging into something pretty significant in healthcare hospital readmissions, specifically after vascular surgery.
Absolutely. And it's a big topic because, well, look at U.S. healthcare spending. Over $3.6 trillion back in 2020.
And heading towards $6 trillion by 2028, right? That's staggering.
It really is. So there's this huge push for cost containment, for getting value, and readmissions. They're kind of a key part of that conversation.
Okay, so why the focus on readmissions specifically? How do they tie into quality and cost?
Well, an unplanned readmission, shortly after someone leaves the hospital, it suggests maybe something didn't go quite right.
Like the initial treatment wasn't fully effective, or maybe the discharge planning?
Exactly. Either of those or both. It raises questions. And it's not just about quality perception. It has a real financial impact.
How big an impact are we talking?
Estimates suggest Medicare might be losing something like $12 billion a year just from potentially preventable readmissions.
12 billion. Okay, yeah, that's serious money.
Definitely. And that's why you have programs like the Affordable Care Act and specifically the Hospital Readmissions Reduction Program, the HRRP, really zeroing in on this.
Right, the HRRP. Refresh my memory. How does that actually work? What's the stick, so to speak?
So the HRRP, run by CMS, basically looks at hospitals with readmission rates that are higher than expected for certain conditions.
Higher than expected compared to, like, a national benchmark.
Yeah, compared to a benchmark based on national data, adjusted for some patient factors, they look back over 3 years. If a hospital's rates are too high,
Penalties kick in.
they can reduce the hospital's payments for all Medicare patients based on what's called a diagnosis-related group, or DRG, system.
So it's not just for the specific conditions being tracked.
No, it affects their overall Medicare payments.
Right.
And the penalty can go up to a 3% reduction.
Wow, 3% across the board. That must really get hospitals' attention.
It absolutely does. DRG payments are a huge chunk of revenue for most hospitals, so a 3% hit is pretty substantial.
What conditions did they start with when this program launched?
They began in 2012 focusing on some really common major issues. Heart attacks, acute myocardial infarction, heart failure, and pneumonia.
Okay, big medical conditions. Did they expand it later to include surgical stuff?
They did. Over time, they added conditions more relevant to surgeons, including vascular surgeons. COPD, hip, and knee replacements came in around 2015.
And heart bypass surgery.
Yep. CABG, coronary artery bypass grafting, was added in 2017. So the scope definitely widened.
Okay, so with that context, let's zoom in on vascular surgery itself. How do the readmission rates look there? I imagine it's complex.
It is. I mean, measuring surgical quality is always tricky, isn't it? Remember Lord Kelvin. If you cannot measure it, you cannot improve it.
Right. But measurement is hard here.
Especially in vascular. These patients often have so many other health problems, comorbidities. So a readmission might not just be about the surgery itself, It could be related to underlying diabetes or heart disease, things maybe beyond the surgeon's direct control post-op.
That makes sense.
Yeah.
So what are the actual numbers telling us for vascular readmissions?
Well, there's quite a bit of variation. If you look at surgical patients overall, the average 30-day readmission rate is maybe around 11%.
Okay, about 1 in 9.
Yeah. But for vascular surgery patients, it generally trends higher, significantly higher in some studies.
Like how much higher?
One study in the VA system, for instance, found a 16% rate for vascular patients. That was compared to just under 10% for orthopedics in the same system.
16%? Wow.
And that's just one study. Across the board, depending on the specific procedure and patient group, you might see reported rates anywhere from, say, 9% up to even 24% within 30 days.
That's a really wide range. Are certain vascular procedures more prone to readmissions than others?
Oh, definitely. Lower extremity bypass for leg circulation problems, that often comes up. Rates around 15% within 30 days aren't uncommon.
15% just for that procedure.
Yeah. And it can go even higher. Think about something like creating dialysis access in the arm, even as an outpatient procedure. Some studies show readmission rates climbing towards almost 50% within 90 days for those patients.
Nearly half. Goodness. What about really major emergencies?
Right, like an aortic dissection or similar acute aortic problems. After someone's initially hospitalized for that, the readmission risk can be incredibly high, potentially up to 60% over a longer period. The initial severity is a huge factor.
Those numbers are sobering. So what typically brings these vascular patients back to the hospital? What are the main culprits?
Several things pop up frequently. Surgical site infections are a big one. Problems related to blood clots like DVT, even if it was treated.
Okay, infections, clots. What else?
And then cardiovascular or cerebrovascular events, so heart problems or stroke-like issues. These are common drivers.
And I assume these readmissions add a lot to the overall cost.
Oh, absolutely.
Mm-hmm.
Readmissions are expensive. On average, a readmission costs about 61% more than the initial hospital stay did.
61% more.
Yeah. And you see specific patterns, like after carotid surgery to prevent stroke, cardiac issues are a pretty common reason for coming back, maybe in 6.5% to almost 10% of cases.
So managing those underlying risks is key. Now, what about this wrinkle? Readmission to a different hospital. Does that happen often?
It does. It adds another layer of complexity for sure. For emergency general surgery patients, maybe around 15% get readmitted somewhere else.
And does that affect outcomes? Is it worse to go to a different place?
Well, initially, some data suggested it was linked to higher mortality. But when they adjusted for how sick the patients were and the types of hospitals involved, that link became a bit fuzzier, less clear-cut.
Interesting. So it's not a simple cause and effect.
Not necessarily, but here's a contrast. For elective major surgeries, being readmitted to the same hospital where the surgery happened was actually linked to a lower risk of dying within 90 days, like a 26% reduction.
26% lower risk. That's substantial. Suggests continuity of care really matters.
It really seems to. Familiarity with the patient, the specific procedure they had, it likely helps.
So why might someone end up at a different hospital for readmission?
Often it's things like infections again, or maybe worsening heart failure, or just the progression of their underlying vascular disease.
More medical type reasons sometimes.
Sometimes, yes. Especially if we look at complex aortic repairs, readmissions to a different hospital are often for those kinds of medical issues. Whereas readmissions back to the original hospital might be more frequently related to a specific complication from the aneurysm repair itself.
What about for peripheral artery disease, like those leg bypasses?
For lower extremity procedures, yeah, data suggests over a quarter, maybe 25% of readmissions happen at a non-index hospital.
And are there factors that make that more likely?
Some studies point to things like being female, having a longer initial hospital stay, and having more comorbidities, a higher Charlson Comorbidity Index score.
Okay, let's talk cost again. Is it more or less expensive if the readmission is at a different hospital?
Interestingly, some data suggests those non-index hospital readmissions might actually be, on average, a bit less expensive.
Less expensive? Why would that be?
The thinking is it might be because they're often for those medical complications we mentioned, which might not require another big, expensive procedure.
Ah, okay. But if a procedure is needed.
Right. If the readmission does require reintervention, like fixing a leak in an aneurysm stent graft, an endoleak, or dealing with a blocked bypass graft, those readmissions are significantly more costly than ones managed non-operatively, like treating a wound infection with IV antibiotics.
Makes sense. You mentioned bypass grafts. Does the type of initial surgery, like open versus minimally invasive endovascular, affect readmission risk or cost?
Older studies didn't show a huge difference there, but more recent data seems to indicate that having an open lower extremity bypass, specifically, is an independent risk factor for being readmitted.
Okay, good to know. So shifting gears a bit, if we want to prevent these readmissions, we need to know who's most at risk. What are the strongest predictors?
Well, there are definitely preoperative factors that play a role. Things like the patient's overall health status, what we call the ASA class. Having an open wound before surgery, already being an inpatient before the operation, being on dialysis, having diabetes, those all contribute.
Right, the patient's baseline health.
Exactly. But what seem to be even stronger predictors are complications that happen after the surgery.
Things that occur during recovery.
Yes, particularly things like post-discharge infections, deep ones, superficial ones, pneumonia, heart attack, sepsis. If those occur, the risk of readmission shoots way up.
Which makes intuitive sense. Those often require hospitalization.
Precisely. And it's worth highlighting again, infections are a huge piece of this. Maybe around 40% of unplanned readmissions in vascular patients are infection-related in some way.
40%. That really underscores the need for good infection control.
Absolutely. Prevention is key there.
So knowing these risks, what's being done? What interventions are out there to try and bring these rates down?
There's a framework proposed by Brooke and colleagues that kind of looks at the whole patient journey, from selecting the right patients for surgery through the procedure and all the way to post-op follow-up. It helps pinpoint where things can go wrong and where interventions might help.
Like optimizing the patient beforehand.
Yeah, things like prehabilitation are gaining interest. Getting patients fitter before surgery, maybe more exercise, stopping smoking, better nutrition. The idea is to reduce complications later.
Does it matter who does the surgery or where it's done, like surgeon experience or hospital volume?
The link between an individual surgeon's volume and readmissions isn't always super clear, unlike some other outcomes like mortality after carotid surgery where volume matters more.
So a high volume surgeon doesn't necessarily guarantee fewer readmissions.
Not automatically. There's some evidence in other fields like pancreatic surgery, but for vascular, surgeon factors seem to explain only a small part of the readmission variation, maybe only 3% or so.
What about the hospital overall?
Hospital volume seems more consistently linked. Hospitals that do a lot of vascular procedures generally tend to have lower readmission rates.
Okay, higher hospital volume seems better. Any other hospital factors?
Little things can matter, like getting the discharge summary done quickly. If it's delayed more than 3 days after discharge, that's linked to a higher readmission risk.
Communication breakdown, maybe?
Could be. And we talked about infections. A post-op wound infection after AAA repair significantly bumps up readmission risk. Same for being discharged to a skilled nursing facility instead of home.
And those also affect long-term survival, right?
Alarmingly, yes.
Yeah.
Both wound infection and discharge to SNF after AAA repair are linked to significantly higher mortality risk within the first year.
That's serious. What about those standardized care plans, enhanced recovery pathways, or ERPs? Do they help or hurt with readmissions?
That's an interesting one. There was some worry that getting patients out faster with ERPs might lead to more readmissions, but the data generally doesn't show that.
So faster discharge isn't necessarily riskier for readmission.
It doesn't seem to be. In fact, some studies suggest ERPs might even reduce readmissions. By standardizing care, improving coordination, you might actually get better outcomes.
Any specific examples?
Yeah, one study on an ERP for lower extremity bypass found it not only shortened the hospital stay and cut costs by about $10,000 per patient, but it also significantly reduced the 30-day readmission rate, dropped from 21% down to 7%.
Wow, from 21% to 7%. That's a massive improvement.
It really is. Suggests optimizing that whole perioperative process can make a big difference.
What about the impact of the big policy changes, like the HRRP penalties? Did they actually move the needle?
There's some evidence hospitals did react when the penalties were first announced for medical conditions. And for surgical procedures like CAG and hip knee replacements, readmission rates were actually already trending down before the specific penalties hit them.
Like hospitals were anticipating it.
Possibly. Or maybe it was just a spillover effect from the focus on medical conditions. But here's the thing. After the procedure-specific penalty started, the rate of decline didn't really speed up much further.
Suggesting maybe there's a limit, a floor to how low you can push these rates with penalties alone.
That could be part of it. It suggests we might be hitting diminishing returns with that specific approach. And unfortunately, other strategies like using telemedicine to manage heart failure patients post-discharge haven't consistently shown a clear benefit for reducing readmissions or mortality in studies so far.
Okay, so it sounds like while focusing on 30-day readmissions has had some effect, using it as the main yardstick for quality has real drawbacks.
That's a really crucial point. Yes, rates generally came down between 2012 and 2015, especially for the targeted conditions, and it didn't seem to just push people into observation stays instead. So, some positive signs.
But
It's still just one metric, a proxy. How well it truly reflects the overall quality of care is debatable.
does it correlate well with other quality measures?
It correlates somewhat with things like surgical volume, as we discussed, and maybe operative mortality, but not necessarily with whether hospitals are following all the recommended best practices the process measures.
And you mentioned variability earlier.
Right. A hospital's ranking on readmissions can bounce around quite a bit from year to year. That suggests there's a fair amount of random chance involved, or other factors that aren't stable. Relying too heavily on it can be, well, misleading.
Are there factors outside the hospital's walls that mess with these numbers, things they can't easily control?
Oh, absolutely. Community factors are huge. Think about safety net hospitals serving really vulnerable populations.
Right, patients with fewer resources, more complex social situations.
Exactly. And in those settings, studies show that often the majority of readmissions after general surgery might not even be directly related to the original surgery.
Really? What causes them then?
It's often driven more by patient-specific issues, social determinants of health, things like new infections, sometimes related to issues like IV drug use or just not having enough support at home, problems with getting follow-up care.
Which raises the question of how many readmissions are truly preventable by the hospital.
Precisely. And the estimates on that vary wildly. Some say less than a third are preventable, others say maybe closer to 60%. It really depends on who you ask and how you define preventable.
And this disproportionately affects safety net hospitals under the penalty system.
It certainly seems to. They often get penalized more heavily, which has led to calls for adjusting the penalties based on patient demographics or social risk factors.
Otherwise, you're penalizing them for the community issues they serve.
You could argue that. Plus, there's the potential for double jeopardy, getting dinged if a complication happens initially, and then getting dinged again if that complication leads to a readmission.
And the data itself isn't perfect either, is it?
No, definitely not. The source matters. Administrative data used for billing might not perfectly match clinical diagnoses. Planned readmissions sometimes get misclassified as unplanned.
You also mentioned the timing window difference.
Right. Medicare's 30 days starts from discharge. But NSQIP, a big surgical quality database, often counts 30 days from the surgery date.
So if you have a long initial hospital stay.
Exactly. Let's say you're in the hospital for 20 days after surgery. In the NSQIP data, you only have 10 days left in that 30-day window post-discharge, where a readmission would be counted. Medicare still gives you the full 30 days post-discharge. It's called immortal time bias, and it can make NSQIP rates look lower, especially for patients with long initial stays.
That seems like a significant difference in measurement.
It can be, and it's led to suggestions like maybe using shorter windows, like 3 or 7 days, to capture immediate post-discharge issues, or longer windows too, or even shifting to metrics focused specifically on readmissions clearly related to the surgical quality itself.
Okay, so given all these problems with the 30-day metric, what else is on the table? What alternative payment models or quality measures are people looking at?
Well, there's a definite move towards incentives more directly tied to overall value, not just this one readmission metric.
Like what?
Things like bundled payments are a big one. Paying a single fixed amount for an entire episode of care, say, everything involved in a leg bypass, from pre-op to 90 days post-op.
The idea being the hospital and doctors have an incentive to coordinate care and avoid unnecessary costs, like readmissions.
That's the theory. Also, risk-sharing models and accountable care organizations, or ACOs, where groups of providers work together to manage the health and costs for a population of patients.
So rewarding efficiency and good outcomes across the board.
Right. The Society for Vascular Surgery, for example, has actually proposed a specific model like this, an advanced alternative payment model for peripheral artery disease based on bundled payments.
Sounds promising in theory. Any potential pitfalls with bundles?
Yeah, there are concerns, again, particularly for those safety net hospitals.
Because their patients are often sicker or have more complex needs.
Exactly. Take complex diabetic foot wounds. Patients at safety net hospitals might present later, have higher amputation rates due to disease severity and socioeconomic factors. Under a simple bundled payment, these hospitals could end up losing a lot of money because their costs are justifiably higher. The bundles need to be sophisticated enough to account for that patient complexity.
That risk adjustment piece is crucial then. Beyond just the money and metrics, what about what actually matters most to the patient?
That's becoming much more central to the discussion, thankfully. Patient-centered outcomes.
So moving beyond just, did the graft stay open? Did they avoid amputation?
Yes. Those are still vital, obviously.
Right.
But also, what's the patient's quality of life like afterwards? Can they maintain their independence? Can they walk comfortably? What are their goals for the treatment?
Bringing the patient's perspective into the definition of success.
Absolutely. It helps align expectations and ensures we're focused on outcomes that genuinely matter to the person going through the treatment.
And one last area, you mentioned coordination of care. Are there models focused on bringing different specialists together?
Yes, multidisciplinary care models are gaining traction. Instead of just seeing separate specialists, care is organized around the condition like critical limb ischemia or aortic disease.
Bringing vascular surgeons, podiatrists, infectious disease docs, wound care nurses all together.
Exactly. The goal is to reduce duplicated tests, improve communication, make sure everyone's on the same page, and ultimately deliver higher value care.
Have these models shown success?
There are promising examples. In orthopedics, multidisciplinary approaches have helped get patients moving earlier and discharged sooner, often at lower cost. And in vascular surgery itself, a team approach for critical limb ischemia has been linked to significantly better amputation-free survival rates. Double the rate in one study.
Double the rate. That's impressive. Shows the power of collaboration.
It really does suggest that breaking down those traditional silos can lead to tangible benefits for patients.
So wrapping this up, it's clear that hospital readmissions and vascular surgery are, well, incredibly complex.
Absolutely. You've got this constant tension, right, between the need to control costs, the challenge of accurately measuring quality, and the ultimate goal of providing patient-centered care.
And the 30-day readmission metric, while easy to track and financially important because of HRRP, is definitely an imperfect tool.
Deeply imperfect. It's influenced by so many things: the patient's underlying health, their home situation, the hospital's resources, community factors, things far beyond just the technical skill of the surgery.
So the search continues for better ways to measure quality, better ways to intervene effectively. Improving those transitions of care seems key, as does exploring these alternative payment models more thoughtfully.
Definitely. And that brings us to a final thought for you, our listeners. Given everything we've discussed about the limitations of today's readmission metrics, what truly innovative approaches could we design? How can we better capture and actually incentivize high-value, genuinely patient-centered care, not just in vascular surgery, but everywhere in healthcare?
And maybe tied into that, what role should technology and perhaps more importantly, patient engagement itself play in trying to prevent these avoidable hospitalizations before they even happen? Something important to think about.